I will now introduce Dr. Rulam Parekh, the VP Academics at Women's College Hospital, to introduce Dr. Eder before her talk.
Thanks so much, Tamil. I'm very excited to introduce Dr. Lihi Eder. She's a clinician-scientist at Women's College Hospital at the Research Institute and an associate professor of medicine at the University of Toronto. She holds a Canada Research Chair in inflammatory rheumatic diseases, focusing on examining sex and gender as determinants of rheumatic disease outcomes. She has a broad background in rheumatology, expertise in psoriatic arthritis, imaging, and cardiorheumatology. She's the director of the Psoriatic Arthritis program at Women's College Hospital and co-director of the University of Toronto cardiorheumatology program. She's a nationally and internationally recognized research leader with over 200 peer-reviewed applications. She has received several awards, those including on mentorship as well as based on her science, and she's taken on several leadership roles in rheumatology. At the Partnership of Women's Health Research, we're really pleased to honor her with the Women's College Hospital Mid-Career Excellence of Women's Health Research Award. It's one of the first years that we're doing this Power Award, and so we're very excited that she was the successful candidate, which is quite competitive. The award recognizes her achievements in advancing science, improving the quality of care, and mentoring the next generation of researchers. So I'm very excited that you'll get to hear her and hear about her work in rheumatology. Welcome, Lihi.
Thank you so much, Rulam, and thank you, Tamil, for the very kind introduction. And I'm really honored to receive this award and share with you some of the knowledge from research regarding sex and gender differences in psoriatic arthritis. So,
Lihi, just a quick thing. We can still see your presenter mode, so you might just want to go to full screen. Go back to display settings up at the top.
Yeah.
And just swap it. Yeah.
Okay, so I'm a rheumatologist and I treat people with arthritis, and my main area of clinical and research interest is psoriatic arthritis.
Unfortunately, sorry, Lihi, again, it didn't move for some reason. I don't know why. Do others see the full screen?
I don't see the full screen. I see the notes.
Yeah, so you might be better.
Again, do you still see or?
Yeah, maybe close it and then share it again. That might be good. But change the display settings on your computer and then change it. Yeah, that's great. Yeah, so if you just go now to full screen, that'd be great. And then at the bottom, hit presenter view.
Save?
Yeah, that's it. Perfect. All set. Now you can talk. All right. Sorry, I'll stop interrupting.
There always need to be some kind of a technical issue, so that's okay. And so I am studying psoriatic arthritis. I'll tell you about psoriatic arthritis because I assume most of you are not familiar with this condition, but generally the message and the insights that we've been finding are relevant to many rheumatic diseases like rheumatoid arthritis and other types of arthritis. And I think we can identify some things that are relevant to people living with arthritis in general that could hopefully potentially inform care in the future. So these are some disclosures. I do research with the industry, which is not really relevant to this talk, but I just kind of acknowledge that. And I'm going to be discussing the sex and gender related differences that we can identify in people with psoriatic arthritis, and as it relates to diagnosis, to response to treatment, and discuss some of the mechanisms that could potentially explain these differences. They are both biological and sociocultural gender-related differences. And then I'll try as we go along to show you how these lessons could be applied in clinic and for those who are clinicians. So Just to make sure that we are all on the same page, I wanted to review when we discuss sex and gender. I know this audience is very educated and informed, but still there are some confusion with the term sex and gender in the medical literature, and many times they are used interchangeably in the wrong context. So when we discuss or talk about sex, we refer to biological attributes that are related to the biological sex assigned at birth for males and females. And these are relevant to biological mechanisms. In the context of arthritis, this could be related to the immune system, differences in immune system, differences in sex hormones, differences in pain processing in the brain and in the peripheral nervous system, and pharmacokinetics of drugs that are different between males and females. Gender, on the other hand, is more complex, and it's a sociocultural construct that refers to being men, women, or gender diverse in different societies and across history. So therefore, it is a more fluid and is changing construct. And for example, with being a woman in Canada is very different than being a woman in more traditional societies across the world, because this determines the behavior and gender roles and risk-taking behavior and lifestyle changes, and also access to care, different societies, different countries. So it is definitely more complex to measure, but still could have a huge effect on the outcomes in medicine, in arthritis, and care. And often distinguish the biological from the socio-cultural aspects of gender is quite challenging. We also know that generally in medicine, and definitely in rheumatology, we tend to treat men and women, males and females similarly. We don't typically, other than maybe in the context of pregnancy, at least in rheumatology, we don't have specific guidelines for males and females. And this is true for other conditions, but this one-size-fits-all approach may be missing or placing patients at risk. An example is in the hypertension field. The conventional approach was to setting similar cutoff for blood pressure for males and females. And more recent studies have shown that this normal cutoff might place females at a higher risk for developing cardiovascular events, and therefore they should potentially be considered to have hypertension at a lower threshold. So, and there are some guidelines that speak to that. However, in rheumatology, we don't have that, and many of the challenges of creating specific guidelines for males and females or considerations regarding treatment is that we have a significant gender data gap. So we just don't know what the differences are, especially when it comes to treatment response. And this is to illustrate this. We published a meta-analysis in Lancet Rheumatology a couple of years ago, where we reviewed clinical trial data of biologic and advanced therapies. And we've shown that very few of these clinical trials actually report sex disaggregated data. So only about a third of the trials reported results of their studies or the efficacy of these studies and by sex, and only 4% reported the safety data by sex. So if trials are not reporting these results by sex, it's almost impossible to identify gaps or differences between males and females. So let's move on to rheumatology, and rheumatic diseases have, there is difference in the risk of developing rheumatic diseases. And generally speaking, when we consider autoimmune conditions like lupus and Sjogren. These are diseases that are driven mostly by B cells, production of autoantibodies. They tend to show higher prevalence in females. So if you see here, there is a 9-to-1 ratio in Sjogren. So females are at much higher risk of developing these conditions, same with lupus and same with rheumatoid arthritis. On the other hand, there are other types of arthritis like gout that is mostly driven by metabolic abnormalities, obesity, and metabolic syndrome. These tend to be more common in male patients. Psoriatic arthritis belongs to a group of conditions that is called seronegative, so there is no involvement or minimal involvement of B cells, and it tends to affect males and females with a similar risk. So, to the non-rheumatologist people in the audience, I'll just briefly describe what psoriatic arthritis is. And so psoriatic arthritis is the second most common type of inflammatory rheumatic disease or inflammatory arthritis after rheumatoid arthritis. And it is a very heterogeneous condition. So it's involving both the skin and the joints. It affects about a third of the people with psoriasis, which is by itself a type of chronic inflammatory disease of the skin that affects about 2 to 3% of the general population. So about a third of those will develop arthritis. And it can affect different joints. So it can affect the spine. It can affect the joints themselves, like peripheral arthritis, can affect the nails and the entasis. Entasis are the insertions of the tendon to the bone. And there is a unique type of inflammation that is called dactylitis. It's swelling of the entire finger or the joint. And overall, it's quite a complex disease because of its heterogeneity and because of the involvement of both the skin and the joints. And it can be a challenging disease to manage. And there is more understanding regarding the mechanisms that are driving both psoriasis and psoriatic arthritis. We know that there are immune conditions, and we also know that there are several factors that play a role. So the understanding is that there is an interaction between the immune system in the skin or in the gut and microbes or other external stimuli, and this could trigger inflammation at the skin. And from the skin, it could then migrate, these cells can migrate into the joints or the tendons and cause inflammation. So the triggers could be infection, could be trauma, like biomechanical stress, and the role of obesity and metabolic abnormalities are also more recently highlighted. And as well as the microbiome, the gut microbiome, there is some data to suggest that changes in the microbiome could lead to these changes in activation of the immune system. Overall, the mechanisms that are activated are mostly T cells, and in particular, in special type of T cells, Th17 cells that produce cytokines and interleukin 17, TNF, and interleukin 23 are T cytokines. And they are important because they are now biologic treatments that could target these cytokines and these activated immune cells and very effectively treat the skin and the joint inflammation. One of the challenges in psoriatic arthritis is the fact that we don't have specific biomarkers. We don't have a particular blood test that could identify whether someone has psoriatic arthritis or not, because it is a seronegative disease. There is no antibody that we can measure. So a rheumatologist really needs to consider the clinical picture, the complaints of the patients, the finding of the physical exam, and a variety of tests, blood tests and x-rays and other imaging, and then reach a diagnosis. And this complexity often leads to delays in diagnosis because there are many other conditions that could mimic psoriatic arthritis. So after this introduction, I just wanted to review with you some of the insights about sex and gender differences and how they could affect treatment outcome, they could affect outcomes of patients in general, and discuss some of the mechanisms that are driving this. So you remember I mentioned that psoriatic arthritis affects men and women in a similar rates, but the presentation of disease is different. So generally speaking, there has been quite a lot of studies now that were published and shown that female patients tend to have higher levels of pain, as well as more pain, higher scores in pain-sensitive domains. So what I mean by that is they tend to have more tender joints. So when we examine as rheumatologists, we examine the joints, we count the number of joints that are tender and swollen. Women tend to have higher score there. They rate the level of pain as higher. And there is also higher levels of fatigue and more impact on quality of life and physical function compared to male patients. And when we look at male patients, on the other hand, we tend to see more severe psoriasis. They tend to have more skin disease. They tend to have more restriction in their joints, especially in the spine. And they also have higher levels of CRP, which is an inflammatory marker. And so these are some differences that have been consistently shown. And another important finding is that male patients tend to develop more severe damage in their joints, in the spine, as well as in the peripheral joints when we use X-rays. And this is kind of a discrepancy between males and females, where even though females have more pain and more impact on their quality of life and function, males tend to have more severe damage in their joints. And so this is important because X-rays are commonly used by family physicians and by rheumatologists to help with the diagnosis of psoriatic arthritis. So if we see less damage in females, it means that it's possible that they develop this damage at a later stage in their disease, or they are less likely to develop damage, or we need more sensitive imaging modalities like MRI or ultrasound that are more expensive and may not be ordered, because if X-rays is the only imaging modality that is ordered and relied on for diagnosis, this could lead to missing opportunities to identify female patients, to make a diagnosis at an earlier stage. And this could lead to delays in diagnosis. So one potential message for clinicians is to consider more sensitive imaging modalities in the diagnostic process of female patients that are being seen or suspected psoriatic arthritis. This has been shown in other types of inflammatory arthritis, so it's not necessarily unique to this condition. Another area where differences have been seen in terms of related to sex or gender of the patient is in the journey to the diagnosis. And this is a study that we've conducted using the Ontario administrative data, and we looked at 3 types of inflammatory arthritis: psoriatic arthritis, rheumatoid arthritis, and ankylosing spondylitis. And we were interested in the period prior to the diagnosis and looking at the patient journey. So as you all know, in Canada, patients cannot see a rheumatologist without a referral from their family physician. So it's up to the family physician to interpret the patient's symptoms and refer them in time to see a specialist. And we hypothesized that there is this period before people receive a diagnosis that they see their family physician for musculoskeletal complaints like pain, joint swelling, stiffness, where these delays might occur. And we've shown here, and we looked at records from family physicians in people who were just recently diagnosed as having one of these conditions. And what we've shown here is that indeed it was more frequent among females to see their family physicians for non-specific musculoskeletal symptoms. So they were seeing them for pain and other symptoms, and receiving diagnosis of non-specific conditions as well, like osteoarthritis, fibromyalgia, these conditions that do not necessarily need referral to rheumatologists. And these could potentially lead to delays in diagnosis. But what was the finding that was more interesting, in my opinion, was the fact that many of these people actually saw a rheumatologist and were given other types of diagnosis. Again, not a diagnosis of psoriatic arthritis or rheumatoid arthritis, but other non-specific diagnoses that do not necessarily need to be treated aggressively and probably being discharged from care. And here you can see that the odds ratio between males and females range from 1.5 to more than 2. So suggesting that delays can occur not just at the family physician level, but they can also occur at the level of the rheumatologist, because it's possible that rheumatologists are also having hard time making a diagnosis of psoriatic arthritis because of various reasons. And some of the reasons I mentioned already, the fact that female patients tend to have a delayed damage. So if they approach their family physician, and the family physician does order x-rays and it's showing a normal x-ray, may reassure them that nothing is wrong, but they are actually missing an early disease. And the atypical presentation, where female patients tend to present with more diffuse pain, is also could also confuse physicians, because they might attribute these symptoms to fibromyalgia, which is more of a chronic pain condition rather than rheumatic condition. We also know that there are differences in health-seeking behavior. Women tend to see their GPs or their healthcare providers at an earlier stage of diseases, where there might be less objective findings, and therefore it's harder even for specialists like rheumatologists to establish a diagnosis when there are symptoms, but there are very little objective findings on x-rays or physical exam. And finally, there are biases, and I wanted to mention biases because I don't know how many healthcare providers or physicians we have here on the talk today, but I think all of us have biases, and it's important to recognize them. Gender biases exist, and we know from research in other conditions and in other musculoskeletal conditions that female patients are more likely to have or to receive psychosomatic diagnosis for musculoskeletal pain. And the notion that males or men are typically in most societies are brought up with the idea that expressing pain is considered to be a weakness, whereas for women it's okay to express pain, might lead to the notion by healthcare providers that if men reports pain, then there must be something wrong and we need to act on that. And for women, it might be just their anxiety that is acting up. So I think we all need to be aware of these biases, and we need to consider pain and consider all the causes and order the necessary tests to make sure that we're not missing anything. And that could be a step to try and mitigate these biases. And I wanted to move on to discuss treatment effects, because this is an area that we are actively doing research on, and I think it's very interesting because it has a potential of informing selection of drugs. And there are still biases in terms of drug developments at to different stages of development of different drugs, starting from preclinical phases, basic science, and many times are still using single-sex mice models, and with little consideration of sex, and this could lead to missing opportunities to identify important targets that might be more relevant in one sex than the other. Phase 1 are stages where use healthy controls, healthy individuals, and mostly to assess safety of drugs or adverse effects. And these typically refer to the standard 70 kilogram healthy male, and therefore this could lead to the fact that we are overdosing female patients. And then clinical trials, phase 2, 3, and then post-approval surveillance of drugs. At least until recently in rheumatology, but also in other fields, did not report sex disaggregated data, did not collect data regarding gender attributes or menopause, for example, and therefore identifying gaps or differences is nearly impossible when we don't know what the differences are. So these gaps could lead to the fact that most of the prescription drugs that are withdrawn from the market pose greater risk for women. And we typically don't consider the sex of the patient when we prescribe drugs, at least in rheumatology, other than in the context of pregnancy or conception. And we don't consider it in selection of drugs or dosing. And this is an unusual example where the FDA approved sex-specific dosing of zolpidem, which is a sleeping pill, because the standard dose posed greater risk for female patients. So the suggestion was to start at a lower dose and then increase the dose as needed, as opposed to men where the higher dose was approved. And I think it's a great example to show that when we have data, this could directly inform care of patients and make sure that both the efficacy and the safety of drugs are taken into consideration, and we can personalize care by considering the sex of the individual. So a little bit about treatments in psoriatic arthritis. So psoriatic arthritis, people experience pain and stiffness and fatigue as a result of inflammation in their joints and in the skin. So the primary goal of treatment is to reduce the level of inflammation to the lowest possible level. And by doing that, we hope to improve patient symptoms, to prevent damage from happening. And there is also data that we can improve longer-term outcomes, including development of comorbidities like cardiovascular diseases, as well as reduce mortality by controlling inflammation. And we're very fortunate in this field that we have lots of targets, because over the past 20 years, there's been huge advances in care. Because of the understanding of the immunology of this condition, there's a lot of biologic therapies that were developed in targeting different cytokines and different pathways within the immune system. And so these are all injectable drugs that target specific cytokines, and then there are other oral medications that are JAK inhibitors and phosphodiesterase, foreign inhibitor that target intracellular pathways. And these are all very expensive drugs, and they are also very effective, but also have some risks involved in these therapies. But despite the fact that we have lots of options for treatment, there are still significant gaps in care, because this is data from Canada, but other countries are showing similar findings. Only about a third of our patients are reaching a minimal disease activity state. So despite the fact that we have very effective drugs, many patients are unable to achieve these optimal treatment targets. You may not be surprised, but women or females tend to have lower chances of achieving a minimal disease activity state. So, as part of trying to understand and describe the differences in response to these advanced therapies, we performed a systematic literature review and a meta-analysis. I mentioned it before, it was published a couple of years ago. We reviewed the literature and the published phase 3 trials that involved these advanced therapies, overall 54 randomized controlled trials, involving over 22,000 patients with an equal distribution of males and females, which is what we expect in the general population. One of the aims of this was to describe the burden of disease at trial entry. And here we reported that similar findings to what I mentioned before. Female patients tend to have more tender joints, they tend to have more pain and more physical dysfunction, whereas male patients tend to have higher levels of inflammation, more severe psoriasis, and more dactylitis. So even when they start these trials, males and females started at a different point. What was most interesting to us was looking at response between males and females. So the primary efficacy of these biologic therapies is typically reported as ACR response, American College of Rheumatology response. 20 mean about 20% improvement. ACR response is a composite outcome measure that includes tender and swollen joints, pain level, the patient and physician global assessment, as well as CRP. So it comprises different parameters together, and it's commonly used in clinical trials to assess efficacy of medications. If you look at the forest plot here, you can see that overall, we found that male patients have 50% higher chances of achieving response compared to female patients. But when you look at the different classes of biologic therapies, you can see that for these 4 classes, this was true that males have higher chances of achieving ACR response, but for this JAK-TYK2 inhibitor, which is a different molecule, it's more downstream in the immune pathway, there was no difference between males and females. Currently, the current practice is that we don't have anything that guides our selection of these biologic treatments other than in relatively rare situations. And if these are all showing preference response in males, while this class shows similar response in males and females, it's possible that selecting or prioritizing this class in females might give better response in female patients. So this was the idea that we are currently trying to understand and study. And to strengthen these results, there is data from real-world cohorts. And this example is from a French registry that looked at almost 15,000 patients starting these different types of biologic therapies. And similarly, they show that male patients are more likely to persist on these biologic therapies, and whereas for the JAK inhibitors, which is that other class, there was a similar persistence. So again, supporting the notion that there may be some mechanistic differences in response between males and females to the different biologic therapies. And it brings up the question, should we prioritize this class in female patients? I think because we don't have, the ideal scenario would be to do a female-only head-to-head study between 2 classes of drugs. I don't see drug companies doing that. And But this is certainly interesting, and right now we're trying to understand the mechanism. So I would walk you through some of the thinking and some of the mechanisms that could also explain why female patients tend to have more pain and maybe better response to these JAK inhibitors. And pain is a theme that comes up again and again. And in psoriatic arthritis, and as well as in other types of musculoskeletal conditions, women tend to report higher scores of pain. And also in experimental pain models, women tend to have lower threshold of pain. So when in an experimental model, example is that participants are asked to put their hand in ice cold water and keep it in there as long as they can, and then women tend to withdraw at an earlier stage. So that this is an example. And there is also a difference in the way men and women describe pain. I mentioned diffuse type of pain is thought to be involving some mechanisms in the brain that are associated with what is called central sensitization or fibromyalgia. It tends to be more common in female patients, whereas in men, the pain tends to be more localized to the joints. So this suggests that there might be some neurological differences in pain mechanisms. And we know that there are both qualitative and quantitative differences in the nervous system between male and females, and this could influence how pain is being processed and perceived by people. And an example for this is that studies have shown that in response to an injury in the peripheral nerves, in males, there is involvement of cells that are called microglia cells, whereas in females, T cells might be involved. And sex hormones, estrogen and testosterone, could influence the transition from this more female phenotype to male phenotype type of processing of pain. So the bottom line is that it's not just the quantity of pain, so more pain or less pain. There are some differences in the mechanisms in the cells that are involved, and may explain why some pain medications work better in males than in females and vice versa. So it's not just the level of pain, it's also more qualitative differences. Why is this important? Because specifically when we think about the medications that I mentioned, the biological drugs are very heavy drugs. They are large molecules that don't penetrate the blood-brain barriers, and therefore may have less influence on more central pain and processing. Whereas the JAK inhibitors are small molecules that can penetrate the blood-brain barrier, and it was thought that they might have a central effect. So if pain in female patients might have a central component to it, they might act better in female patients. And there are some clues for this in another type of inflammatory arthritis called rheumatoid arthritis, where they've shown that they compare JAK inhibitors to another biologic therapy, TNF inhibitor, and show that when these drugs are used as second and third line, they are better at producing the level of pain than the TNF inhibitor. And again, we do need consider sex-specific trials to study these questions. These are mostly clues. In psoriatic arthritis, there is very little data and there is very little head-to-head studies to compare, but there was one study that looked at a JAK inhibitor versus a TNF inhibitor, and this one didn't show that observation. So this mechanism remains hypothesis. And the other potential reason for seeing these differences between biologic drugs and small molecules could be immunogenicity. So one of the problems of these biologic drugs is that our body can develop antibodies that would neutralize the effect of these drugs. Female patients have a higher tendency for autoimmunity and development of these antibodies, and therefore, considering these small molecules that are chemical products and are not associated with development of these neutralizing antibodies is another consideration that we may need to, or may explain why these molecules might work better in females than males. And this brings me to differences in immune response. And I did mention that there are differences in the immune system between males and females. We know that B cells tend to be influenced by estrogen. They tend to be more active and produce more antibodies. And this is the reason why females tend to have more autoimmune conditions and develop greater response to vaccination, while male patients are more susceptible for infections and at high risk of malignancy because of these reasons. We looked at some of the differences in the immune profile. So psoriatic arthritis is driven by abnormalities in the immune system. So potentially there are differences in the immune profile that one profile might respond more to some of these drugs that I mentioned, whereas others might be more suitable for female patients. And so this is a study that was led by Stephen Dunn, who is a PhD student in my lab, and we looked at the protein profile of male and female patients with psoriatic arthritis and compared them to age and sex matched controls. We were interested in identifying immune and inflammatory pathways that might be more relevant to male or female. One of the key findings here was that we found a lot more deregulated pathways in male patients compared to female patients, so 24 more proteins that were deregulated in males. And this was surprising to us. So even though there were about 21% of the proteins that were shared between males and females, you can see that most of the deregulated proteins were in males and very few in females. And this is a complex image, but what it shows is that it identifies the proteins that were deregulated, and then these proteins are part of biological networks and pathways. And so the green labels are showing you the pathways that are different between males and females. And some of these, or many of these pathways are very relevant to the immune system. An example is the IL-18 signaling. And there is another signaling pathways within the cells called Rho GPPAs that has been associated with response to biologic therapies, neutrophil activation, and other pathways that are all connected to the immune function and the effect of abnormalities in the immune function. So, and these are just to show us that there are, even though we call the disease psoriatic arthritis and both males and females show some similarities, there are also many differences in pathways that are driving this disease and might be relevant to treatment. And some of these might serve as better targets for males or for females. And lastly, I wanted to briefly talk about menopause. There is hardly any research on menopause in psoriatic arthritis or rheumatic diseases in general, and this is in contrast to a lot of research done in other conditions like cardiovascular diseases or osteoporosis. And we know that menopause can present with different symptoms, and many of the symptoms are symptoms that are often experienced by people living with arthritis. And examples are bone pain or joint pain. In many patients, we surveyed almost 40% of the people, of the women, going through menopause have any joint pain. Other symptoms are fatigue, mood changes, depression, and skin changes. they are all very relevant to people that already have psoriatic arthritis because first, it's very hard for us as rheumatologists to attribute whether these symptoms are due to their arthritis or whether this is because they are going through menopause. And I can tell you that as a rheumatologist, I have never been educated about the fact that joint pain is one of the symptoms of menopause. So it would be very likely that rheumatologists would attribute menopause-related joint pain to the arthritis and potentially switch therapy or do unnecessary tests when these might be just transitioning through menopause and could potentially respond to hormone replacement therapy. We decided to look into our cohort and see what is happening during menopause, because one of the reasons is the fact that some of the symptoms can be related to menopause, but another reason is that potentially the declining levels of estrogen could lead to changes in the immune system. So there is potentially also some changes that can happen in disease activity during this time. We used the Toronto cohort, which is a cohort that started in 1978. It's a long time ago. And people that are being seen in our clinics are enrolled in this study, and they are seen using standardized questionnaires and standardized protocols. So we have a huge database that tracks disease activity and patient-reported outcomes over time. And the important fact is that we also have information about whether the participant is at menopause and at what age. So we looked into this and we defined this perimenopause period as being 2 years before, 2 years after the final menstrual period. We also looked at broader time windows, but this window showed the greatest change. And I think you can only need to look at this graph to show you that when looking at this measure of disease activity called DAPSA, so again, it's a composite outcome measure, there is an increase in disease activity that starts about 7 years prior to the final period and continues after that for about 3 to 4 years. That there is a significant increase in disease activity, more pain, more tender joints, more swollen joints, more severe psoriasis. There is some decline after that, and there is a later increase in disease activity that we didn't look into that, but could be attributed to other reasons. The bottom line is that this is the first time this is being described and has not been described in other cohorts, not even in more common conditions like rheumatoid arthritis, and it just suggests that something is happening there in disease activity around menopause, whether these are just the symptoms of menopause or that there is some activation of the immune system that is happening due to changes in estrogen level. We are not sure. And in this particular cohort, very small proportion of participants used HRT, so 1.5%. And the question is, of course, could HRT help with that? We don't know. And this is something that we are very interested in and currently studying. So I'm going to summarize this, and I've shown you that there are significant differences in the way psoriatic arthritis present in male and female patients. This could influence the journey to diagnosis. It could influence monitoring of disease activity, and it could influence potentially drug response. And we need to understand better the mechanisms that are driving these, because these could be related to pain, and pain is definitely, there is more burden of pain in female, in women. And this means that we need to make sure that we're not missing inflammation. So we need to use more sensitive imaging modalities in female patients. But regardless, we do need to make sure that we are managing pain in both men and women, regardless of the cause. And menopause could also have an influence on symptoms, and whether this requires referral to a specialist to consider HRTs still remains an open question. And the messages regarding research, I think there are still significant gaps in reporting sex disaggregated data in both observational and clinical trials, but I can say that being in this field, I can see a change, and more trials now, at least in my field, are reporting sex disaggregated data and starting to consider sex in trial design, for example, stratification by sex that has been implemented recently, but there is still work to be done. And just to highlight this ongoing research that we are leading here from Women's College Hospital, it's a study that is funded by the CIHR in BRAPA, which is an international organization. And what we're doing here is we're trying to understand the mechanisms. So understand the biological mechanisms related to sex, but also trying to understand what is the effect of gender. And this is through the purposeful collection of gender-related data regarding social support, caregivers, gender role, gender identity, and so on. And this is through an observational study that involves almost 600 patients now with finished recruitment, patients starting treatment with advanced therapies. And the study includes about 40 sites across the world, including sites in Asia and in Latin America, Europe, North America. So it will generate a large database that would have the necessary data to try and separate these biological from sociocultural construct and hopefully inform care in the future. So I wanted to thank Women's College Research Institute for supporting me. I wanted to thank Empower for this award, and this is my team here and our funders. And thank you for your attention.
Thank you so much, Lihi. This was a fascinating talk and so exciting to hear about these advances in the research that you're doing. Thank you for showing us that last study. This is really the frontier where we're able to untangle sex and gender. We have just a few minutes if there are questions from the audience. You can put up your hand or unmute, turn on your video. I have one. Those insights about diagnosis. So the evidence seems very clear.
Is Emil frozen just for me, or?
I think Tamil got cut off.
Well, well, we have a couple of seconds till she comes back. I just want to say that was really a masterclass of how to incorporate sex and gender, like from the underlying biology through diagnosis, treatment, everything. That was really just fantastic work. Really impressive stuff.
Thank you so much, Frank. It's nice to see how it's influencing. It's fascinating to see how it can influence so many aspects of care and how little we understand.
Go ahead, Frank. I was just going to emphasize what Frank said and say that there's so much more that we all need to do,
Exactly.
Camille, I think
I dropped out. I'm sorry. I was asking a question about moving those clinical insights into practice. If there are any promise that, is it through clinician scientists like you who are champions? Is it through national and international guidelines? How do we do this?
So yeah, I think and data is gender data gap is, I think, currently, at least in my field, is the main problem. It's very hard to design or to inform guidelines without knowledge. And so this is what we're trying to do right now. This is our more immediate goals. I can say that, at least in my field, I'm involved in the guidelines for psoriatic arthritis by GRAPPA, and this is the first time that there's going to be a statement about considering sex of the individual, and more so in terms of the monitoring and diagnosis. So some of the messages that I try to convey, and I think it's doing the research and knowledge translation is also important, because many people are unaware of this, at least clinicians are unaware. And we need to we convince clinicians by showing them data. So it's hard to convince someone that this is important and could inform care beyond just saying, oh, women have more pain. We need to understand what are the biological mechanisms so we can help with selecting the better medications. And so research.
Can I ask Lihi, how did the community take it when there was this emphasis with, stratified by sex and gender? Was there resistance for other trialists thinking about what they should do?
So
companies?
I say that whenever I present this in conferences like rheumatologists, there is really a lot of interest, because this is really something that could help us inform care. So this is really well received. And where I did find some blockages with industry, that there are some concerns stratifying and reporting sex stratified data, because if it shows that the medication is less effective in one sex, especially with new drugs, this could potentially affect the marketing, or so this is where there are some challenges. But I can say that, as I mentioned, I do see change in people ask for these data, and companies are reporting it more so than before. And being involved in some trial design, there is also some acceptance of the importance of collecting the data as trial design, like sex stratification by sex is something that was implemented recently.
Yeah, I find it so fascinating about the pain specifically, because that mechanism is so interesting, how it's different. And so you do wonder about how companies are actually trying to develop things now that are different. And is there a way that we could, really, continue to push for that kind of science, right? So I think it'd be great. Thank you so much.
Thank you, and thank you everyone for attending. Power will hold its next Women's Health Research Seminar Series on April 15th, focusing on women's sexual dysfunction. And thank you so much, Dr. Eder and Dr. Parekh. This was fantastic and really built the case for why we need more women's health research.
Thank you so much. Bye.
Bye, Lihi. Thank you.